Our last presentation for this afternoon is Morbidity and Mortality in the Antiphospholipid Syndrome during the 10-year period, a multi-center prospective study of 1,000 patients by Dr. Serrano et al., and will be presented by her from a number of centers in Europe.
Good afternoon. On behalf of Europhospholipid Project, I want to thank the organizing committee for choosing our abstract as our oral presentation. As you all well know, the antiphospholipid syndrome is a systemic autoimmune disorder characterized by a combination of thrombosis, pregnancy morbidity, and rise titer of antiphospholipid antibodies. At the present time, we have scarce information regarding the long term of APS, relation to evolution of clinical manifestation, association with other autoimmune disorders, appearance of catastrophic APS, and long-term mortality. So the aim of our study is to assess the frequency and characteristics of the main causes of morbidity and mortality in APS after 10 years of follow-up. The Europhospholipid Project is an European multi-center observational and prospective study where 20 tertiary referral centers from 13 countries from all Europe participate, as you can see in the map. This cohort includes 1,000 patients with criteria for classification of definite APS. Europhospholipid Project started in 1999, has been followed during 10 years, and the observational period stopped in 2009 or before if patients were lost or died. The diagnosis of manifestation was firmly confirmed according to support criteria, and a standard protocol was used to collect data. Variables evaluated were sociodemographic, comorbidities, associated autoimmune disease, more than 100 clinical manifestations, laboratory items, treatment, causes of death, and survival. The Europhospholipid Project has been evaluated in 3 different points during the evolution of the cohort. At baseline, at 5 years, and now at 10 years follow-up that is going to be presented today. The variables were analyzed using a standard statistical test, and the main results we obtained are presented in the following slide. This table shows the loss and death during the long-term study. The patients' loss during the second period accounted for only 5% each year. Of the entire cohort, more than 80% were female. The mean age at the study was 42 years old, and the majority of patients were white. At baseline, 36% of patients had APS associated to SLE, and more than 50% had primary APS. Of those patients with primary APS during the 10 years of follow-up, 8 of them were reclassified as associated with lupus-like syndrome, and only 3 reclassified as associated with SLE, all of them during the second period. Also, 9 patients developed an episode of catastrophic antiphospholipid syndrome, and all of them during the first period. This table shows the main clinical manifestation ordered by frequency at baseline, 5 years, and 10 years follow-up. At second period, the most common recurrent thrombotic events were stroke, transient ischemic attacks, and deep vein thrombosis. Cardiac involvement, as valve thickening and dysfunction, were more frequent in the second period. Additionally, several manifestations not included in classification criteria were also common, like thrombocytopenia, livedo reticularis, and autoimmune hemolytic anemia. The main obstetric manifestation about that, 188 pregnancies occurred during the long-term study. 73% succeeding in having one or more live births, higher than 48% at baseline. The most common obstetric complications were early pregnancy loss, and regarding fetal morbidity, intrauterine growth, restriction, and prematurity were more frequent in the second period. As for treatment, the majority of patients were receiving antiaggregator and/or anticoagulant agent. 7% of these patients presented bleeding. Regarding mortality, the mean age at death was 59 years old, and mortality rate was similar in both periods, around 5%. The total rate mortality was 9%. The most common causes of death were bacterial infection, severe thrombotic events like myocardial infarction, stroke, and pulmonary embolisms, and also hemorrhages. In relation catastrophic syndrome, 5 of the 9 patients died. That means more than 55%. In this Kaplan-Meier survival curve, so that at 5 years, the probability of remaining alive was 95%, and at 10 years, at the end of the study, was 91%. So we conclude that arterial thrombosis, stroke, transient ischemic attacks, and myocardial infarction, and deep vein thrombosis were the most common recurrent thrombotic events during long-term study. The prevalence of the catastrophic APS was infrequent but presented high mortality rate. Almost 3/4 pregnancies succeeded in having one or more live births. Fetal morbidity was more frequent during the long-term study. The total mortality rate at 10 years was 9%, and infections, severe thrombotic events, and hemorrhage accounted for this high rate of mortality. So our take-home messages are that patients with APS develop significant morbidity and mortality at 10 years of follow-up despite the current treatment. So it's imperative to increase the effort in determining optimal prognostic markers and therapeutic measures to prevent this important complication of the antiphospholipid syndrome. Thank you very much.
Thank you, Dr. Serrano. The paper is now open for discussion. May I ask you a question? I would like to know how to define the lupus-like syndrome, because you have given the data that at least more than 1/3 of the patients, of the APS patients, were associated with a lupus-like picture.
Yes, this patient started get the anti-DNA positive, and doesn't have a criteria classification of SLE. Okay. So maybe Alzheimer's and anti-DNA positive only. Yes.
Okay, thank you.
Six of them were in the first period, and 2 in the second period.
Over there.
Here, one question. About the 9 patients with CAPS, with catastrophic syndrome, could you tell me something else, if you know which was the factor associated with the development of catastrophic syndrome in those patients?
When or what?
The risk factors.
Los factores de riesgo por los pacientes que desarrollaron catastrófico síndrome.
No, we don't look that.
Okay.
Sorry.
Sorry, do you have a stratified mortality according to age intervals? Age intervals, edad, por intervalos de edad.
No, we looked at, but we haven't a statistical difference between demographic.
No, because, you know, for example, 9% of mortality is not the same within the last period, 50 years, between 50 and 80s, than between 20 and 40.
Yes, I don't know.
If you have the survival rate analyzed per age intervals.
The interval between the survival?
No, the survival rate by age group.
The survival analysis.
Yes. Ricardo Vera is going to help me.
El análisis, si hiciste el tiempo de sobrevida o tiempo de evento en función de grupos etarios por intervalos etarios.
No.
Survival by age group.
Hiciste todo el pool.
All the group.
Excuse me, Gloria Vázquez from Colombia. How do you explain their high rate of infections?
Yes, a good question. Maybe in SLE patient, maybe because of the treatment and the immunosuppressive treatment. We don't know yet in primary APS.